So welcome to the debriefing. Here we are going through the hemodynamics and the cardiac support. A patient after coronary artery surgery develops severe hemoptysis after inflation of the pulmonary artery catheter balloon. A new infiltrate at the tip of the catheter is seen on the chest X-ray. What is the cause? So the history is quite clear that the pulmonary artery has ruptured because of the PO catheter, and the immediate management would be to do a temporary hemostasis by wedging the balloon into the affected artery, thereby preventing further loss and isolating that lung so that the patient the normal lung does not get soiled with the blood. So in patients with hemoptysis, it is not usually because of the blood loss that the patients die. The patients often die because of hypoxemia, because more and more alveoli get flooded with blood, and that becomes the cause of severe hypoxemia and the cause of death as well. So it is important that we isolate the bleeding lung till the source of the bleeding is controlled. PEEP can be applied to increase the resistance of the pulmonary vasculature, and eventually cardiothoracic repair or angioembolization by interventional in the cath lab can also be attempted. Describe the indications of cardiac output management in the ICU. So, cardiac output measurement in the ICU can be done in complex cases who have deranged cardiac function with shock. It could also be given in cases of multifactorial shock states where there are multiple causes for the shock, maybe a combination of cardiogenic, septic, where we are, and even obstructive shock. So, we are doing a goal-directed resuscitation. Continuous monitoring is often required, often in patients, high-risk patients after cardiac or non-cardiac surgeries, and hemodynamically unstable patients, often protocol demands us to do cardiac output monitoring. What is the normal relationship between mixed venous oxygen saturation and central venous oxygen saturation? So in central venous oxygen saturation, because we take the sample from the SVC, often it has a lower saturation as compared to the mixed venous oxygen saturation. So the saturation which we collect from the pulmonary artery catheter is a little higher, because the one which comes from the IVC is less, more saturated. And reversal is seen often in cases where we increase the cerebral blood flow so that the extraction of oxygen from the brain is lesser, because the blood flow is enough, and if the brain function is depressed, so that the oxygen extraction in the brain is lesser. So in cases of anesthesia, even patients in head injury where cerebral metabolism is depressed, it could be one of the reasons. And in cases of shock, when there is a diversion of blood from the splanchnic circulation and there is increased oxygen extraction, that is the reason when the IVC saturation also decreases, and eventually the mixed venous oxygen saturation will be lower than the central venous oxygen saturation. What abnormality is seen? Here we see a swing in the arterial waveform, and this is because of this is called as pulsus paradoxus or pulse pressure variation, which is seen in pericardial effusion, asthma, and severely hypovolemic patients in mechanical ventilator. 50-year-old man was admitted with dyspnea, hypotension. Clinical examination reveals a tachypneic patient with a heart rate of 170, which is a sinus rhythm, a blood pressure of 90/60. The JVP is raised, cardiac murmur was audible, although because of tachycardia, it could not be timed with certainty. Hemodynamic monitoring shows a high CVP, PA pressures are 48/24, occlusion pressure is also high at 22. Three likely causes for the above clinical presentation. Okay. So, in any case of left ventricular failure, cardiogenic shock, so it is a cardiogenic shock. The other causes will be mitral regurgitation or acute aortic incompetence also may cause this kind of a picture. List 5 causes of mixed venous oxygen saturation, a recording of 86%. So, septic shock, left to right shunts, high FiO2. So, there is a higher mixed venous oxygen saturation. That means extraction of the oxygen in the periphery either is low, or the delivery of the oxygen, high FiO2 is there, or there is a direct mixing of the blood which is happening from left to right shunt, which is happening. So, in septic shock, where the extraction is less, left to right shunt, so that the oxygenated blood is mixing with the deoxygenated blood in the right ventricle, so the mixed oxygenous oxygen will increase. High FiO2, where the PO2 is very high or the saturation is very high already. In cases of hyperbaric oxygenation, error of measurement and reduced oxygen consumption may also be seen in cases of hypothermia, neuromuscular blockade, hypothyroidism, and general anesthesia. Cause of fall in the blood pressure, so the sinus rhythm has gone into atrial fibrillation, and this fast ventricular rate is with a lack of atrial contribution is causing this fall in the blood pressure. The following information was obtained during the insertion of the right heart catheter. What dominant abnormality is indicated by the right heart catheter data and two likely causes? So the RA pressure is 14, RB is 105/14, okay, which is also high. PA pressures is 33/18, higher. PA occlusion pressure is fine, and the cardiac index is a low that is 9.4. So you have to, you see that the pressure gradient between the RV and the PA is high. The PA occlusion pressure is lesser, so there is nothing problematic in the left heart per se. Okay, but the RV pressure is significantly higher to overcome the PA pressure. That means there is some obstruction which is there between the RV and the PA. So the PA pressure is acceptable. 33/18 is not significantly high. PA occlusion pressure is also not significantly high, but the RV pressure is significantly high, the systolic specifically, and the RA pressure is back pressure wise, it is higher. So there's pulmonary valve stenosis or supravalvular or RV OT obstruction. So there's basically obstruction to the RV outflow tract. Okay. So stenosis of the RV OT or pulmonary valve stenosis can give this kind of a picture. So there's an increased pressure gradient between the RV and the PA. What is being done? How does it help? List two conditions in which this test is unreliable. So what we are doing is a passive leg raising test, and it helps to assess the fluid responsiveness. It is unreliable when the patient is severely hypovolemic, as the blood stored in the lower body is already insufficient to augment the stroke volume. Also, it is unreliable in cases of abdominal compartment syndrome and intra-abdominal hypertension. Below is a tracing of the Swan-Ganz catheter, why there is a sudden change in the waveform. So when it is pulled back, the pressures fall, and it is because the patient's Swan-Ganz is filled back in the RV. That is why this diastolic pressure has fallen down to 0. How do you interpret the IABP? So this IABP, if you can see, it is causing an early inflation. So it's the 1:2 augmentation with early inflation of the balloon. So what happens when you early inflate? When you inflate early, the aortic valve closes early. The left ventricle has increased afterload to empty. So that is more oxygen demand is there. What does the curve C depend? So this is a pressure volume loop, the curve of the heart, wherein the curve C shows that there is a higher increase in the pressure as compared to a lower increase in the volume. So at low volumes only the pressures are higher. So this increases the decreased compliance of the left heart, which could be decreased compliance. That means there is decreased relaxation. So impaired relaxation, poor LV relaxation, increased thickness of the LV with the LV hypertrophy, pericardial tamponade, and high PEEP may give this kind of a picture. 57-year-old man shifted to the ICU after pancreatic necrosectomy, trace of the flow track. The flow track trace, if you see, the SVV is 23. The map is acceptable with SVV slightly high, CVP is very low. So goes in favor of having volume depletion. So increased SVV, low stroke volume, and cardiac index, which requires volume resuscitation. What is happening here? So initially there's a junctional rhythm which reverts to a sinus rhythm, and the low BP when it reverts to sinus is better, and you can see Canon A waves in the CVP trace. So there is a junctional rhythm which is causing Canon A waves. Coming to the next topic, that is drugs, fluids, and transfusion. So what is the evidence of albumin containing solutions in the management of critically ill patients? The role is quite controversial. SAFE study confirms that the 4% albumin administration was safe when compared to normal saline in those critically ill patients who required fluid resuscitation, but it did not give any specific indications where this should be used. So the specific predetermined and the stratified subset of patients where there is still significant doubt, like in patients with multiple trauma, there seem to be worse outcomes in the albumin group. So in cases of, especially with brain injury, head injury, severe head injury, and cases of multiple trauma, this albumin should be better avoided. Two prospective RCTs have demonstrated specific situations where it is of benefit, like in patients who are hypoproteinemic with acute lung injury, it can be used, and in patients with spontaneous bacterial peritonitis. So there are very limited uses of albumin actually as per the current scenario. Okay, we use it for spontaneous bacterial peritonitis or in patients who require large volume paracentesis, and also in cases of hepatorenal syndrome, and also it can be used in hypoproteinemic patients with acute lung injury to avoid excess fluid to be given and express seeping out, leaking of the fluid. Indications and complications with the use of soda bicarb 8.4%. So indication is when you use it for treating metabolic acidosis, but it is better avoided. It should be used only when the pH is very low or patient has very high vasopressor support and the responsiveness of the vasopressor is reduced. So we give bicarb to increase this vasopressor responsiveness. Hyperkalemia, it has a very proven role. Role in contrast-induced nephropathy is now controversial and not better avoided. Also, it is useful in cases of salicylate poisoning. The complications that we face because of use of bicarb is because it has high sodium content. It can cause it is hyperosmolar, and it causes paradoxical intracellular acidosis, increases CO2 production, causes hypokalemia, alkalosis, and shift of the oxygen dissociation curve to the left. Phlebitis also can occur. So it can also lead to hypernatremia and fluid overload in patients who have a low EF. Rationale for using hypertonic saline in traumatic brain injury. So, when in traumatic brain injury, especially if the BP is low, you prefer to use hypertonic saline because it compensates for the blood loss, maintains the osmotic pressure. So, it improves the cerebral perfusion pressure, reduces harmful inflammatory responses, prevents cerebral edema. Can be used as a continuous infusion and obviates the need for a osmolarity testing, which is often required with mannitol. List of major biochemical abnormalities that are usually associated with the refeeding syndrome. So refeeding syndrome, often what we see is there is a drop in most of the electrolytes, that is phosphorus, potassium, and magnesium. These are the three electrolytes which are affected, which go down, and there is increased glucose, that is hyperglycemia. 75-year-old man on indapamide for hypertension presented with seizures after a 7-day history of increasing lethargy. She was unwell, dry mucous membranes, decreased skin turgor with a BP of 88/50. Her serum sodium was low, that is 103. By day 5 of her admission, the serum sodium has increased to 141. The antihypertensive therapy was adjusted and she was discharged home. 10 days after the initial presentation, she is readmitted with ataxia and confusion. And on examination, she's afebrile with a GCS of 14. V4 is V4. No neck stiffness, tremors are present, ataxia is present, drooling of saliva is present, brisk jaw jerk, bilaterally brisk reflexes, extensor plantars, nil significant on the WBC full blood count or on the liver function test, and you're asked to come to assess for the aspiration. So this probably has gone into pontine demyelination because of rapid correction of sodium, which was done. Another alternative explanation for this patient would be a brainstem stroke. So she's having tremors, ataxia, with drooling of saliva. And if there's a clear-cut history that for hypertension and unwell hypertension with low sodium, that was rapidly corrected by day 5 to 141. So this could be pontine demyelination or a brainstem stroke. Patients at risk of pontine demyelination, osmotic demyelination with sodium correction are mainly malnourished patients, alcoholics who are chronically malnourished, hypokalemic patients, patients with burns, and elderly women who are on thiazide therapy. What do you understand by the term balanced crystalloid solution? Is NS a balanced? So when we say balanced crystalline solution, that means the contents of the electrolytes in the fluid that are there in the fluid that we give are closer to the content of these same electrolytes in the extracellular fluid of the body. Okay, so they have the least adverse effects on the electrolyte balance as well as the acid-base balance. So the normal saline is not a physiological or a balanced solution because the sodium is 154 and our normal sodium is around 135, 140, and the chloride is also 154 and normal chloride is 100 to 105. Contraindications to succinylcholine. Succinylcholine, the main problem contraindications are based on potassium levels and also in cases of raised ICP. So hyperkalemia is a contraindication. It is prone to develop mitral malignant hyperthermia. It should be avoided after 5 days in patients with burns, crush injury, or neuromuscular disorders. Again, because it causes these disorders after 5 days, there will be upregulation of the nicotinic receptors and there will be more release of potassium from the muscles when succinylcholine is used and cause hyperkalemia and even arrest. Repeated doses of succinylcholine can cause bradycardia, it can cause fasciculation, it elevates all pressures in the body, that is intraocular pressures, intracranial pressures, intra-abdominal pressures. So it is avoided in these situations. 3 bacteria which are not covered by meropenem. So MRSA is not covered, Enterococcus faecium is not covered, Fecalis is covered, but faecium is not covered. New Delhi metallo-beta-lactamases are not covered, Stenotrophomonas and Acinetobacters are not covered. Clindamycin, mechanism of action and side effects. So clindamycin blocks the protein synthesis by impeding release of the protein from the 50S ribosome. So protein synthesis basically by impeding the release of protein from the 50S ribosome, similar to macrolides. Okay. So the toxicity is there is rashes, fever, anaphylaxis, erythema multiforme are known, and there is a high incidence of Clostridium difficile infection. May block the neuromuscular transmission and contraindicated in patients with myasthenia. List ways in which critical illness can change the pharmacokinetics of antibiotic therapy. So pharmacokinetics can change at every level, right from absorption. So oral bioavailability is unpredictable, especially when there is ileus or diarrhea or when there is bowel edema. So it slows down the absorption when the peripheral blood flow is hampered. Then the distribution is impaired because the volume of distribution increases because of excess body water, which is there because of the edema. Also, the protein binding reduces, so it shortens the T half and increases the amount of free drug, especially in ceftriaxone. Then elimination is affected because the metabolism, biotransformation, excretion is affected by the liver function specifically, and also by the excretion in the kidney function by the liver, and kidney is affected by the biliary obstruction, renal clearance by renal thing is affected. Role of immunonutrition in the management of critically ill patients. So there is no role of immunonutrition. There is some role of glutamine in burns. What is the pharmacology and uses of vasopressin? Vasopressin is a hormone neurotransmitter, direct action on a number of receptors, that is V1, where it causes vasoconstriction, V2, which is in the kidneys, which causes antidiuresis, and then the V3 in pituitary. It also has acts on oxytocin receptor subtypes and P2 receptors. It is rapidly inactivated by trypsin peptidases, so it has a very short half-life in within minutes. Longer if effect is there on the kidneys, at even at very low concentrations, it has longer effects. So uses is it is useful in cases of diabetes insipidus, where it can be given IM, IV, or even intranasal. It can be given as IV infusion to increase the blood pressure in cases of vasodilatory shock at the rate of 0.01 to 0.1 units per minute. Amiodarone, the pharmacology and uses. So, amiodarone is a class 3 antiarrhythmic. It prolongs the action potential duration, prolongs the refractory period of atrium, nodal, or ventricular tissues. It is highly protein bound with high apparent volume of distribution, accumulates in the adipose tissue, and highly perfused organs. Half life is 14 to 59 days. So, up to 2 months is the half life of amiodarone, and it is mainly excreted by the liver and then the bile. Uses are, we all know, for ventricular tachycardia, in refractory ventricular fibrillation, in cases of arrest situation, in atrial fibrillation, the uses are. So coming to quality, safety, and accreditation. So a new level 3 ICU has been built in your hospital. Patients are going to be admitted next week. And the director of the ICU services gives you the job of testing the gas supplies and the suctions that have been installed are appropriate and working satisfactory. What aspects will you check? So you need to check that all the outlets have the right gases in them. So whether the labeling is proper, the color coding is proper, make sure that the static pressure at the outlet is proper. That is oxygen and air as at 415 kilopascals, and suction outlets are at negative 60 kilopascals. Make sure the gas pressure does not drop when the flow is turned up. So when there are higher flows required, the gas pressure should not drop. So the change in pressure should be less than 10 for air and oxygen and less than 15 for suction. Make sure that there are low pressure alarms which are quite visible and audible, both of them are working. Okay. Patient presence to the ICU with hemoptysis has been intubated, bronchoscopy is planned to isolate the source of the bleeding. He has just been diagnosed as having pulmonary tuberculosis on the basis of a positive smear and has not received any treatment. Discuss the precautions that you would take. So when you go in such a room, of course, you have to the care that you take is that the patient should be in a single room with negative pressure ventilation with at least 12 air exchanges per hour. So if you're putting a patient on the ventilator in the ICU, you need to make sure that you're putting him in a negative pressure room with 12 air changes per hour. Bacterial filter should be there in the ventilatory circuit and a closed suction should be used. All staff who are entering the room should wear a personal protective equipment, including N95 mask or an N100 mask, and infection warning sign should be put up. If bronchoscopy is undertaken, then we should minimize the generation of aerosols. So patient should be paralyzed so that coughing is prevented. Apneic oxygenation during bronchoscopy should be preferred, and powered air purifying respirator if consider use of powered air purifier respirator if available. What design features of the above equipment prevent it from being connected to the oxygen outlet device? So these are color coded, these are size coded. So oxygen is white, suction is yellow, and there's a unique sleeve index arrangement. So the size of the sleeve which enters inside is different. So all will not fit into the same. So there are different sleeve sizes or sleeve index which is there. Busy Saturday morning in your fully occupied 14 bed ICU. A fire suddenly develops in the electrical switching box besides the central bed. What are the principles of handling this emergency? So all patients, remove all patients and staff from the immediate danger area. This means you have to safely disconnect the lines, monitors, ventilators, and move these patients towards the exit and back the ventilated patients. Notify the switchboard, activate the fire alarm, state the location or nature of the fire, Shut the AU doors and windows, turn off all the oxygen outlets wherever possible, attempt to control or extinguish the fire with the extinguishers, fire blankets. If it is uncontrolled, evacuation of the patient should be started as early as possible. There should be a reverse triage evacuation, that is the patients who have higher chances of survival. So the visitors will be evacuated first, then the stable patients, and lastly the unstable patients will be evacuated. What are the important elements of a medical emergency team program? So, call criteria for alerting the team to a sick patient, so medical emergency team, education of the ward staff to recognize which patient is going to deteriorate, then training and composition of the MET team who has diagnostic as well as procedural skills, review of the calls, aggregation of data and follow-up reduces, and MET team has found to reduce the patient morbidity as well as mortality. So these are the teams which go to the wards when there is an emergency, then they go and visit the ward. Outline the factors you would consider in making a cost benefit analysis of introducing a new component of care into your ICU. So, whenever we put a new component, a new care component, first of all, we need to see that this strength of evidence for this care is adequate. That means this should be a proven methodology, and there should be external validity of trials or supporting information which you are able to extrapolate to your own patients that you are managing. So, they should be applicable to your patient also. Also, you should identify which patients are going to be beneficial from your patients. So it should not be applied to all kind of things. So you should accurately identify for which patients you have to use this new method or new procedure. Magnitude of outcome benefit should be found. So number needed to treat should be there. Consider survival to hospital versus 30 days survival versus 12-month survival. Additional costs which may be generated by achieving that outcome, like cost of hospitalization, other care incurred after survival, comparison with this cost which are generated with the alternative strategy which is already there. So what are the costs that you're going to generate and what are the costs that you're going to use? So what is going to be the funding for the cost should also be considered, that the new care which has come up. What is standardized mortality ratio? Outline the limitations of using this ratio to compare the performance of the ICU. So standardized mortality ratio is defined as the observed mortality by the expected mortality. So need to estimate expected mortality rate using a scoring system, Apache 2 or 3, SARS 2 or MPM score, better than comparison of non-adjusted mortality. So standardized mortality basically compares the expected mortality rate using a scoring system. So there is some of about a standardized mortality which is there. The potential limitations of the system are multiple, including inconsistencies and inaccuracies with collection of data, scoring, missing data may be there, patient mix may not be the same. There may be more severe patients which are admitted to my one ICU compared to the other ICU. Number of patients will be smaller, so the error will be more. There is accuracy of the prediction model is doubtful. Mortality as a surrogate marker for quality of care is again a doubtful thing. You cannot take mortality as a marker for quality of care, and eventually cost of use of the proprietary system. So standardized mortality ratio is not what can be used for comparing two ICUs. You're asked to put in place initiatives to improve hand washing in your ICU. List what initiatives would you use. So educate, put signages everywhere, introduce the best products. So if your products dry the skin, obviously people will not use it. Keep sinks available, audit them, and give the feedback to the staff. List the desirable features of the illness severity scoring system for the ICU patients. So the ideal scoring systems should be calculated on basis of easily or routinely recordable variables. They should not be very difficult. It should be well calibrated. There should be a high level of discrimination. It should be applicable to all populations in the ICU, and can be used in different countries. The ability to predict mortality, functional status, or quality of life after ICU discharge. Factors for minimizing medication errors: optimize the medication process, standardize it, computerized entry should be there, clear entry, barcode technology to indent, computerized infusion devices, and reconciliation medication. Better nurse patient ratio and working hours also adds to the medication safety process. You have been asked by your director to assist in planning and development of a new level 2 ICU. Define what is meant by 1, 2, and 3 level ICUs, that are levels of ICU. So level 1 ICU is one who is capable of providing immediate resuscitation and short-term cardiorespiratory support for the critically ill patients. It will also have a major role in monitoring Prevention of complications in at-risk medical and surgical patients. It must be capable of providing mechanical ventilation, simple invasive cardiovascular monitoring for a period of at least several hours. Level 2 provides high standard of general ICU care, including complex multi-system life support, which supports the hospital's delineated responsibilities. And Level 3 ICU is a tertiary referral unit for ICU patients and be capable of providing comprehensive critical care, including complex multi-system life support for an indefinite period. Level 3 units should have a demonstrated commitment to academic education and research. All patients admitted to the units must be referred for management to the attending ICU patient. So it is a level 3 is the highest level of the ICU. Outline how you plan ICU response to an influenza pandemic. First is activate the pandemic plan. Planning should be done with all other departments of the ICU, ambulance services, all other departments in the hospital, including ambulance services, other hospitals, state department of health. Early detection surveillance should be there. Bed capacity should be increased. New beds should be there. Elective surgeries have to be postponed. Alternative areas need to be identified. Healthcare staffing levels should be there. Anticipate need for new ICU equipment. Infection control measures so that your own staff doesn't get sick and the disease does not spread to other patients as well. So provision of vaccine should be there, and real-time communication link should be between the laboratory and the healthcare administrator. As a newly appointed ICU specialist, you are put in charge of the safety and quality in your ICU. The infection control department informs you that your ICU has a higher than acceptable rate of central line associated bloodstream infections. What are you going to do for your approach? First is train the staff, use of aseptic technique, look at the insertion technique, site what is selected, how the insertion bundle or the checklist has been carried out. Consider limiting insertion to few more experienced operators who are than to every operator. Document daily review, remove lines at the earliest. Look for evidence for using antimicrobial impregnated line and biopatches or chlorhexidine plus alcohol disinfectant. Consider alternative to conventional CVC, like you may consider using PICC or tunneled. So basically the training, education, continuous surveillance, use of fewer operators who can do it, and deciding what site to be used, daily review of the lines and removing them as early as possible, and alternative methods have to be used. A junior trainee is in distress, has been asked to speak to you regarding a medical error they have made that has resulted into a life-threatening adverse outcome for the patient. So outline the key points of initial discussion with the trainee. So the trainee is basically upset that there's an adverse outcome by him. So first is that the critical incident debriefing should be done, and it should be basically, you should allow the trainee to vent out and tell his version of the events before making any conclusion. Continuous emotional and ongoing psychological support to be present should be given to the trainee or the registrar. For the providing, the family should be given complete disclosure of this of the patient, and clear documentation in the record should be there about what has happened, what was the event. Early contact should be done with the medical legal advisors. Report to the coroner if the patient dies, and the event should be subject to a root cause analysis. So listen to the registrar, give him emotional and psychological support. At the same time, give open disclosure to the family, as well as be ready for a medical legal procedure and activate your medical legal advisors. Counseling should be there so that further training and with regards to further career and training for the trainee, and follow-up meeting should be done with the mentor and the departmental head for the next day. Regarding appraisal of the article, an article appears reporting the positive effects of a new agent in a trial of 50 patients with septic shock. What criteria will you use to assess the validity of this article to your ICU? So the criteria for assessment of such an article include that whether this trial design is valid and powered to achieve a result. If it seems doubtful, but a large effect in a specific group may be detected. So you should look whether you is powered enough or is the design valid enough. Was the hypothesis valid enough, have based on valid evidence, or the hypothesis was vague? Whether all entered patients were accounted for, was the intention to treat analysis, were the groups equivalent even after randomization, was there proper blinding of the study personnel, apart from experimental interventions, were they treated equally? What was the statistical analysis appropriate? How large was the treatment effect? And can the results be applied to our patients? What are parametric tests and what is its limitations? So parametric tests are more accurate, and they assume there are some assumptions that it made about the data. That is, the data is normally distributed. So parametric test is applied only when the data that you have collected for the study is normally distributed. That means there is a bell curve. Okay. If the data deviate strongly from the assumption, the parametric test will lead to inaccurate conclusions. Also, if the sample size is small, the parametric test may lead to inaccurate conclusions due to loss of normality of sample distribution. So the parametric tests are student t-test, analysis of variance, Pearson correlation coefficient, and regression or multiple regression. What is the power of study, and it depends on what factors? So the probability that a study will produce a significant difference at a given significance level is called as the power of the study. So it depends on the difference between the populations compared, the sample size, and the significance levels chosen. So higher the power of the study, higher significant is the study, or valid is the study. What is intention to treat analysis? Intention to treat analysis is means that all the patients who were taken into the study, who were randomized, will be analyzed in the last, whether they were part of the study or whether they left with the study. So it simplifies the task of dealing with suspicious outcomes. That is, if there are any conscious or unconscious attempts to influence the results, it guards against bias about dropping out. So even if the patient has dropped out, still it would be used in the analysis. Preserves the baseline comparativity between the treatment group, which is achieved by randomization, and reflects the way treatments will perform in the population by ignoring adherence when the data are analyzed. What is a meta-analysis? What is the role of meta-analysis in evidence-based medicine? So meta-analysis is a form of systematic review that will also use statistical methods to combine the results from different studies. So the role or advantages of doing a meta-analysis is because it increases the sample size by taking multiple studies. It has more statistical power. It resolves the uncertainty when many studies disagree. It improves estimates of effect size. It establishes questions for further randomized control trials. What is type 1 and type 2 error? So type 1 error is, that means the null hypothesis actually was true, but it was incorrectly rejected. So the type 1 error is may result in the implementation of the therapy that is in fact ineffective or a false positive result. And type 2 error is the null hypothesis was incorrectly accepted. That means it will result in rejection of the effective treatment strategy or a false negative result. So null hypothesis usually we make opposite of what we really want. So if I say that A medicine can be used for this disease, then the null hypothesis is that the A medicine cannot be used for this disease. Okay, so type 1 error is when you are incorrectly rejecting this. That means you will have a false positive. That means you will falsely be using that medicine. What factors influence the sample size of the study? So the sample size of the study has to be dependent on your significance level, what you want to achieve. What is the power of the study? What is the effective size? That is smaller values, that effective size difference. So if you're looking for smaller changes, then you have to look for larger sample size. Also the variance and standard deviation in the underlying population. Large variance means larger sample size. What is receiver operating characteristic plot as applied by a diagnostic test? What are its advantages? So the ROC curve that we see is a graphical representation of sensitivity versus 1 minus specificity for all the observed data values for a given diagnostic test. The advantage is it is simple, graphical, represents accuracy over the entire range of the test. It is independent of prevalence, and the test can be compared on a small scale, allows comparison of accuracy between several tests. With reference to a randomized control trial, what is blinding and allocation concealment? So blinding is when the trial participants, their relatives, caregivers, data collectors, everybody doesn't know which treatment group the individual participant has been attached. That is a blinding. Allocation concealment is an important component of randomization process and refers to the concealment of the allocation of the randomization sequence from both the investigator as well as the patient. Okay, so poor allocation concealment when potential exaggerate treatment effects. So methods used for allocation concealment include seal envelope technique or a telephone or a web-based randomization. So you are initially unaware which group you are going to go to. A prospective observational study. Uh, a prospective observational study examining the association between fluid therapy and outcome reports. The following results were seen. So a prospective observational study examining the association between fluid therapy and outcome reports, the following results were seen. Crude 90-day mortality of patients who received colloids were higher in patients treated exclusively with crystalloids than in patients who were treated with ecdysteroids. So who received colloids had crude mortality, 90-day mortality, which was higher, which was 25.5% versus 15.4, with the odds ratio of 1.84 and 95% confidence interval of 1.56 to 2.18. After multiple logistic regression analysis, the adjusted odds ratio was 0.923 with a p-value of 0.09. Interpret these results. So if you look initially, this shows a significantly higher mortality in patients who had received colloids compared to those who had received crystallites. However, when many other factors which were likely to influence the mortality were taken into account by multiple logistic regression analysis, the difference was no longer statistically significant. So then it interpreted that the fluid choice is not significantly associated with 90-day mortality. What is publication bias and how can this impact the validity of a meta-analysis? So publication bias is a publication of or non-publication of studies depending on the direction and statistical significance of the results. A meta-analysis evaluate studies whether where there has been publication bias will be flawed. So no matter how well conducted in other aspects. So publication bias may also extend to bias of selection of studies for inclusion into meta-analysis based on language, journal of publication, ease of access, field of research, and that is called as a dissemination bias. Okay, so which journal you choose for the meta-analysis, whether the language, how easily it is accessed, what is the field of research. Based on that, this is a dissemination bias. A systematic review of literature was undertaken, which was comparing proton pump inhibitors with H2 receptor blockers for the prevention of GI bleeding in ICU patients. Name the type of graph illustrating. So this is a graph which is going in favor of proton pump inhibitors. So this is a forest plot graph which compares the trials, and PPI use results in odds ratio of 0.35 or reduction in risk of bleeding compared to the H2 receptor blockers. So it does cause a 65% reduction in bleeding as compared to, so the risk ratio is 0.35, which is in favor of PPI. 65% reduction in bleeding as compared for this H2 receptor. What is a non-inferiority trial, and why would a non-inferiority trial be undertaken instead of a superiority trial? So, when an experimental method treatment is not worse than the control treatment by more than a specified margin, so this was a safe alternative treatment that was available. So placebo control trial would be many times would be considered unethical as an established treatment if an established treatment already exists. So the investigations often consider the experimental treatment unlikely to be superior to the established treatment or the current treatment which is already going on, which is highly effective. So then the experimental treatment may offer advantages like safety, reduce the adverse effects, better compliance, lower cost, or more convenience. So then in those cases, we use a non-inferiority trial. What is block randomization? So when you want to make sure that your numbers are kept equal in both the groups, then in those cases we do block randomization so that there's the unequal distribution of the groups is not there, especially when small trials are done. So when A and B are joined, that though P are evaluating, then a block sizes of 4 are formed, then 6 possible blocks of randomization happen. So one of the 6 possible blocks is selected randomly, and the next 4 study participants will assign to the order of the block. The process is then repeated to achieve the necessary sample size. A randomized controlled trial examining a treatment for lung injury reports the following results. The primary outcome was a change in the SOFA score over 96 hours. The mean SOFA score from baseline to 96 hours decreased from 9.8 to 6.8 in the treatment group, that is by 3 points, and it reduced by 3.5 points in the placebo group. And the difference was with a P of 0.86 and the confidence interval minus 1.23 to 1.03. There were 30 pre-specified secondary outcomes. 29 were not significantly different between the treatment and the placebo group. In the exploratory analysis, they did not adjust for multiple comparisons. Day 28 mortality was 46.3 in the placebo group and 29.8 in the treatment group with a P which was significant, that is 0.03%, and the differences between the groups were 16.5%. How do you interpret this result? So the primary outcome did not show a significant difference, and overall the result of the trial is negative. A secondary outcome of a 28-day mortality does show a significant difference in the favor of the treatment. However, as this is one of the 30 secondary outcomes, which has no adjustment for the multiplicity of the testing, this is likely a false positive result and should be interpreted with caution. Coming to communication skills. So in communication skills, we have to be very careful about what we are speaking, and often using words like a multidisciplinary meeting, developing having empathy, eye-to-eye contact, speaking honestly, and giving them a good prognosis or rather the correct prognostic numbers would avoid any conflicts. So let us see a few scenarios. 80-year-old male admitted for elective renal transplant. Pre-op assessment was acceptable. In the OT during anastomosis, he started bleeding profusely. Immediate intervention to stop the bleeding was done. Patient became unresponsive, so multiple transfusions were given. Patient became hypotensive, multiple transfusions given, started with supports, post-surgery shifted to the ICU, ventilator, inotrope, severely acidotic, not pouring urine, and so started on CRT. How will you handle this family? So this family, because this patient is into a pre-renal failure for now, and the new kidney will probably start flicking up once this acute episode is corrected. So the handling of the family would be giving them a prognosis that the prognosis overall would be good. So though they are looking for they were expecting a good outcome. So obviously pre-consent is important, and explaining them that this is a pre-renal and there is a good chances of recovery. There is no intrarenal damage because the blood pressure was maintained throughout the surgery. Okay, and multiple transfusions, and eventually with the correction of CRT, the urine will start may start pouring. Good chances that it will start pouring. 45-year-old man visited to the hospital to meet his friend who was admitted in the ward. When leaving, he started complaining of chest pain and collapsed in the corridor. So the visitor has collapsed. Emergency code blue was activated and started CPR as per ACLS protocol. Immediately shifted to cath lab. Angioplasty done. ROSC was achieved in 40 minutes. Post procedure is shifted to the ICU. Hemodynamics included. Day 5 is not showing signs of any brainstem reflexes, even 48 hours after stopping sedation. How will you explain to the family regarding brain death, and how will you explain them about the brain stem reflexes test? So the prolonged CPR has led to hypoxic ischemic damage, which needs to be explained to the family that a sudden cardiac arrest, which was and fortunately, despite being in the hospital, giving good CPR, and the ROSC overall took up to 40 minutes. So we need to explain that the damage is irreversible, and there are no brainstem reflexes, which involves the protective reflexes like cough, corneal reflexes, and there is no breathing attempt as well. And this patient, with full empathy, we need to explain them that this is an uh, irreversible damage which has happened to the brain. 45-year-old male visited to the hospital to meet his friend who was admitted in the ward. When leaving, he complains of. So we finished this. Sorry. So 80-year-old female, very lean, thin, old stroke, bed-bound, contractures, admitted to the ICU for sepsis. She started responding to treatment. On day 3, son noticed some swelling on the left arm, confirmed on X-ray, left radius ulnar fracture, which was not there at the time of admission. How will you inform this to the son? So we need to tell them that probably because of the osteoporosis, because of the age, there is a high risk of pathological fractures as well on the minimal movement. Also, there's a possibility because she was in sepsis at that moment, and we were more busy in taking care of the sepsis. There is likelihood that it was there at the initial, which we probably did not notice initially. And now, when she's more conscious and complaining, she's got this thing. So, the noticed of the fracture. Okay, so communication skills, you have to again mention the same things that we have to make him take it into confidence and tell him what would the future care, that it would take a long time to recover, and we need to see the osteoporotic index that the patient has. 55-year-old known diabetic, COVID pneumonia, ARDS requiring invasive ventilation, and then on VV ECMO. Oxygenation improved. He was improving, but after day 7, he developed a collapse and went into septic shock. Despite all supports, he deteriorated and arrest. So how do you know the bad news? So the wife was probably expecting a good news because he was overall improving over the last 7 days, and but however he was still in a critical position, and these secondary infections which develop is often because of the compromised immunity and more of intrinsic infections than a extrinsic infection. So with taking the wife in confidence, with the other family members present, we would slowly break the bad news with empathy, maintaining good eye to eye contact, explaining her about the development of a new infection, which probably he could not take it, gone into a rapid shock, which his heart could not sustain, and he collapsed. So these are the scenarios of the table viva which we often see, how you could be divided, and this is how we have made this whole exam. So all the best for your exams, guys. So OSCE, the contents are which we tried to prepare for you all was this, and thank you very much. All the best for your exam.